Hello and welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the financial and non financial disclosures. Dr. Luis Riquelme receives a salary from Barique Speech Language Pathology PC. He also receives an honorarium from Speech Therapy PD for participating in this podcast. His non-financial disclosure is that he is the co-chair of IDDSI, the International Dysphagia Diet Standardization Initiative. My financial disclosure is that I'm the owner and founder of BrainBridge Connect, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on speech therapy PD, I receive financial compensation. I'm also an adjunct instructor for both James Madison University and Old Dominion University. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Dr. Luis Riquelme, PhD, CCC-SLP, BCS-S, Fellow ASHA and ASHA Honors, who is the Consulting Director of Rehabilitation and Speech Language Pathology at Maimonides. I butchered that, sorry.
Maimonides. Maimonides Health.
Maimonides Health, an associate professor, I promise I practice, at Universidad Católica del Uruguay and adjunct professor, Teachers College, Columbia University. His current research focuses on changes in swallow physiology in dementia and pill swallowing. Publications also include relationships between culture and dysphagia. Luis has presented locally and internationally. He serves as co-chair of the IDDSI and a member of ASHA's Healthcare Economics Committee, and as I mentioned, is the recipient of the ASHA Honors and a Fellow of ASHA. Luis, Dr. Riquelme.
Luis works
Gracias.
well. Luis works well.
Gracias, and thank you for being with us this evening. So good to
Thank
see
you
you.
so much for having me. I'm excited about being here. This should be a fun hour.
Yeah, it's always a fun hour. It's always a fun hour. So let's go ahead and just jump right in. Can you just talk to us about your background and how you got into dysphagia research and that being your primary mode of what you spend your day to day doing?
Right. So actually my heart, my passion, and where I really have always been is in clinical practice. And then from clinical practice early on, right, once I received my master's degree and was doing my clinical fellowship at an outpatient rehab facility, then hopped into acute care hospitals and fairly quickly made it to director. Eventually started my practice, and so my practice was the speech pathology team for several hospitals and several nursing homes in Brooklyn and in Queens, New York, for many years. Um, Later on, most of the group, we were at one point, 11 speech pathologists were focused on one major hospital in Brooklyn. And most recently, about 3 years ago, I was recruited to another hospital, Maimonides Medical Center specifically, but Maimonides Health Network, and to run the speech pathology group. And there, my colleague and friend Alexandra Soifer joined me as assistant director. 6 months later, they asked me to also run rehab, and so I inherited PTOT and was also having fun with speech pathology. Even with the administrative titles, I still saw patients every day. I had to go in and do a couple of consults, see some patients, help out. I would say at Maimonides, that wasn't as often as I did before. Um, but throughout my career as a clinician, right, as a speech pathologist, my concept always was there's so much I don't know, I need to learn more. So I kept reading. I was looking at the research. I participating in continuing education. Back then, we didn't have Zoom and all this. You had to go to conferences and pay for hotels and all that. Um, but luckily, I was in New York City where we had access to a lot of good continuing ed in person. And um, and so that's when initially, interestingly, I don't know if you know this, my interest area was the bilingual brain, bilingualism.
Mm-hmm.
And I thought that was fascinating. So I started the doctoral program because I really wanted to explore the bilingual brain a lot, closer. Um, and then for personal reasons, I had to stop the doctorate and for a few years and got involved in politics to the point where 9 years later, I was president of the New York State Speech Language Hearing Association. The 90s was for any seasoned clinicians out there, the 90s were a very crazy time for those of us in healthcare. Lots of changes in long-term care, especially regulations and requirements and so on. And so many clinicians were suddenly faced with okay, I'm being asked to work more hours because of the changes in reimbursement, but what do I do, right? How do I develop a program? How do I get more consults, et cetera, things like that. And so I had to decide between um, making sure that we're doing a good job and that we survive and that we don't fall on our face. And I felt that was more important than going back for my doctorate. But eventually I did. And at that point, I was swept into the whole swallowing thing, right? I knew that from graduate school. Dysphagia has always been my passion, not only because I love eating, but I really love the biomechanics and just the pleasure of it all, if you think about
Mhm.
it. So now I'm technically semi-retired, but I'm still working part-time for Maimonides remotely, and I'm running the postgraduate certificate program in dysphagia at Universidad Católica in Uruguay. And then, in the spare
Yeah, which is
time, co-chairing ITSE and things along those lines, volunteering for ASHA. It's the stuff we do, the stuff we do.
yeah, I know. Sometimes the hours in the day. I was president of our state association in 2020. It doesn't I always say it doesn't get much better than that. It's the thing you want to be president of in the year that we have the first year of the pandemic was really a 10 out of
That's
10 do
true.
not recommend.
Yeah. Yeah, but you know what? And that's when, but look what, if you have to find something positive, look
Oh
what
yeah,
brought. It forced us to be skilled at some of this technology, like using Zoom or Microsoft Teams or any of the other platforms, and
true.
and allowing us to obtain CEUs like this, right? Um,
Hmm.
although I always emphasize, especially to the young clinicians, to know you need to go to some in-person activities as well. That networking is invaluable,
Hmm.
right? Because you might be sitting next to somebody that's in the same setting as you are, but they do things differently, and you might get ideas or you might share some of what you're doing. And so that's how we continue to grow, because that's the
Yeah,
idea. Um,
yeah. Or like me, I just walk up to people that I've been to their courses for years and say, "Hey, this is who I am. I'd love to have you on the podcast." This is what I did to you.
yeah, that sounds
Worked out.
familiar.
It actually worked out. I'm okay with
Yeah,
it.
yeah. There you go. There
Um,
you go.
So let's get into aging and this population of dementia. And I kind of I know we could go all over the place with this, but one of the places I think is a great place to start is talking about presbyphagia because a lot of people aren't they've heard the term, but maybe they're not familiar with exactly what it is and how it manifests and what we see in our clinical practice.
So that's a great start. My interest has always been in the older adult, and that's the population I've always enjoyed clinically, and so it made sense that research-wise, that's also what I was going to focus on. And my dissertation was actually in the area of Parkinson's, but in clinical practice, as I saw the aging population growing. And then looking at some numbers, I mean, right now, 17% of the US population are people over the age of 65, right? And
Hmm.
it's projected that by 2040, that'll go up to almost 22%, right? So those are high numbers. And if you go onto the World Health Organization website, you'll see that this is impacting all continents. Right now, Japan has had a population of people over 65, I believe over 30% of their population age 65 and over for about a decade now. And so they've been really doing some research on, cognitive changes and assisted living and doing all that. But we're seeing more and more countries, right? Some countries in Eastern Europe are going to have those large numbers of, over 30% of the population. World Health Organization used the age of 60, not 65. In South America, there will be some countries, Chile being one of the first ones that will reach those numbers. But Canada will be reaching those numbers before the US. But the US is getting up there based on what I just shared. And so the big question that I always pose is, so how are we going to handle this in healthcare, right? I hear geriatricians saying, oh, after 75 or after 80, people respond differently to medications, right?
Mm-hmm.
So their cardiac medication or their whatever other medication, they don't respond the same way. Their body is now managing that differently. Then we talk about presbyphagia, right? And in 2019, Dr. Ashwini Namasivaya McDonald and I published a paper. She's now at McMaster in Toronto, Canada, and where we posed that we look at, presbyphagia and dysphagia as a continuum, right? And so to me, and people have these other, ideas of presbyphagia, and some people talk about sarcopenic dysphagia, which I don't necessarily, I'm not a big fan of that terminology, because presbyphagia isn't always because of sarcopenia. And so to me, presbyphagia is when you have somebody that's this is a weird term, a functional swallower, right? A person that is swallowing well is engaging in some compensations, maybe not even volitionally, without realizing it, right? And sometimes we see people, they modify their textures a little bit, or they cut their food differently. They're already making some adaptations, but if you ask them if they have a swallowing problem, they say no, right? They just consider that part of it, and they're compensating well. But then they might get sick. They might get a UTI, right, a urinary tract infection, or they might be weak from some other treatment, and so now they're dehydrated and malnourished. Now they can't compensate as well, and so now along that continuum, if we see them, we might say, oh, they do present with a dysphagia, with an oropharyngeal dysphagia that we feel is impacting, and so requires some treatment, right, some form of treatment. But it's a continuum. So maybe once they're medically stable or they get better, they make it over this UTI, right? Or whatever is causing this dehydration and malnutrition, they will come back and they'll be at their baseline, right? And it's not only their baseline data, but actually their baseline compensations for swallowing. So that's what I see as presbyphagia. Why do we need to be smart clinicians and why do we need to be good? Because we need to not go crazy when we do an instrumental exam, right? And we see something different, right? If that different is still allowing for a functional, a safe and efficient swallow, then it's okay, right? That's the way that, who are we to say, oh, you have a swallowing problem, we have to intervene immediately, right? The other important piece and another concerning part of our clinical practice that's based on some research that's actually quite old is well, first let me say, we don't all agree on what dysphagia is, right? And so if you've been watching, we have some of our colleagues received a grant, and that was Deb Suter, Marty Brodsky, and Giselle Mann, to look at the definition for or defining dysphagia. And there hasn't been a good consensus reached, right? And so when we're reading the literature, we need to find out what that group, what those authors are using to define dysphagia, how they're defining dysphagia. Okay, so dysphagia isn't just aspiration, right? So we're talking about safety, but we also have to talk about efficiency, right? So is there residue? How's the coordination, et cetera? So we have to be really careful about that. Now, In that context, let me say this. Laryngeal penetration is normal. And many times we see clinicians on an instrumental exam see one instance of penetration for a particular texture and immediately switching over to another texture. No, that's incorrect. All right. Um, and the same thing with our clinical exam. Oh, the voice was a little wet gurgly, but that was one swallow. And maybe this person
Mm-hmm.
even NPO for days or weeks before, right? So be careful. But we have data. In 1999, Joanne Robbins and her group published the data. They had 3 different groups. And in the older group, the folks over 65, they found that 17.8% of the swallows, they tested thin liquids and semi-solids, there was laryngeal penetration in healthy older adults. Okay. And then Doggett, 2006, found that in people under the age of 50, about 7 to 8% of the swallows, there was laryngeal penetration for thin liquids and semi-solids. And they confirmed that 17.8%, 17 to 18% in people over 50 years old. Okay. So we need to be careful, right? We might follow a protocol during our instrumental that says just, administer 3 swallows of this thin liquid, but we may need to administer more. We may need to administer 6 or 9, right? To find out what's really happening and tie it in with their respiratory status, their lung status, the whole picture. I don't need to educate on that. That's not what we're focused on. But it's concerning because as we see people age, we're going to see some of those differences. And so we need to think like well-educated clinicians and think about function and about quality of life, right? And that's one of the things I love about IDSE, right? The International Dysphagia Diet Standardization
Mm-hmm.
Initiative, because that allows texture modification with greater variety, right? It's not just regular chopped or mechanical soft and puree and that's it, right? You have no other options. Now you've got minced and moist, you got soft and bite-sized, you have many other options. And the other thing is that on one plate, someone can have a variety of different textures, right? Because if on the food pyramid, if they are at a higher number, they can have any of the textures that are below that, and then the liquids, they can have any of the ones that are above. So that's wonderful, and that's all about quality of life. So then we
Well,
have
and from a cultural perspective too, you have to look at what people are eating and what like what my plate looked like tonight for dinner and what, I had for lunch. We tend to have, if we call it a regular diet, we tend to have a variety of textures on our plate at any one given time. So that
Exactly.
makes
So
total
why should the
sense.
person with dysphagia not be able to enjoy that variety, right? And
Mm-hmm.
let's think about the sensory, taste, temperature, texture, volume, right? Why should it all be this mush, right? That I think is
Mm-hmm.
called puree, right? So that's important. But then we start seeing, people are now living longer because they're either healthy or the healthcare system is allowing them to live longer. And so what happens? That's, we know, one of the risk factors for cognitive decline, right? So age, as we get older, we're at higher risk for cognitive decline. And then if we go look at that road and get away from dysphagia, what's interesting about cognitive decline is that we don't understand it, right?
Mm-hmm.
And so, I mean, there's that whole, some people break it down into we've got this preclinical part where it's really not detectable. There are changes in the brain, but the person is still functional. It's not even detectable in cognitive tests or things like that. Until then, we get to MCI, right? The mild cognitive impairment.
Mm-hmm.
And so those are more evident, and those might start, really impacting, but the person's ADLs, right? Their activities of daily living are still okay. So until then, they reach the dementia.
Mm-hmm.
And and globally, I think I mentioned this to you before, Renee. globally, we're not doing a good job at diagnosing the dementias, right?
Yeah.
Um, I mean, sometimes the dementia is diagnosed by the primary care physician, and the
Hmm.
patient's placed on Aricept or some other medication without being sent to a neurologist or a psychiatrist, which in the US would be best practice, to then do their workup to confirm the dementia, maybe determine the type of dementia. So when we see this dementia diagnosis in a patient's medical record, we have to ask, where did this come from? And
Hmm.
how true is it? And we very infrequently see the severity. Is it mild? Is it moderate? Is it severe? Forget the type. So that makes our treatment, our thinking, and how we tackle, in this case, the dysphagia, sometimes quite challenging.
Yeah, and when you think about, you mentioned mild cognitive impairment, and backing up beyond that, we know that for good brain health, nutrition and hydration are such big parts of that. And we do that in a continuum for brain health, from concussions to TBI to there's a lot of push for sports related injuries or athletes who have prehab now for cognitive um, health and brain health. And it's the same way that we're sort of pushing for decreasing the risk that you could develop MCI or you could develop a type of dementia, making
Mhm.
sure that your nutrition is a big part of that. And so if you combine that with some level of dysphagia, then you can see where, again, it's like which came first, the chicken or the egg. And then
Yeah.
also backing way up to when you were talking about medications, I know one of the things that in acute care we had a whole ortho center, and I would often get consults for, AD plusers who fell, broke their hip, and had to have a hip surgery. And what would happen is they were not able to tolerate the anesthesia like they did when they were 40 or 20 or whatever younger age.
Correct.
And they would not really arouse sufficiently. And, you know, you're 2 hours post-op and they want to give you a pain pill, and the patient's in there coughing and sputtering and not even really awake. And so there's so many pieces of this puzzle. It's not one thing or the other. It's just multifaceted. And I think that's where keeping up with the research and being grateful to people like you who are doing the research so that we can say, okay, this was my thought process and now it's validated by this research that's there, that I can then hand to a physician and say, this is not cut and dry like you think. They don't all have oropharyngeal dysphagia post-op. That's not what happened necessarily. Could it? Yeah, of course it could, but
And that education piece really is huge in terms of the multidisciplinary care of the patient, but then also being able to understand, when should they call us, right? When should they call us? What can they do? And us being making sure we're available and we understand. We can't expect others to know exactly what the right time or exactly what to do unless we provide some of that education, because sometimes we
mhm.
don't know it, and it might differ from facility to facility, right? Depending on the style of the clinical team or of the whole healthcare team. Um, I wanted to add to this whole puzzle, the impact of frailty, and there's a really nice article. It's I mean. I guess as time goes by, it's kind of getting old now. It's from 2019. Wow, a whopping 6 years ago, um, by Julia Chikiro in Australia, and it looked at frailty in the context of eating and swallowing, right? And so she talks about, aspiration and choking risk and this whole issue of the modified textures, but also the autonomy of choice. And that's something we can't forget. And when we start looking at ethics, Dr. Paula Leslie, who's now in the UK, is also has some really great literature that makes us really think and start looking at that quality of life and the patient's dignity and patient's choice. So with that, I'll say when I started then looking into this whole aspect of dementia, I was really fortunate to meet and find out that she was just as passionate and interested in this. My colleague and friend, Ashwini Namasivaya McDonald, who's at McMaster, and so we started talking, and there's an interesting amount of literature looking at the behavioral aspects of not eating or of changes in eating behaviors in people with dementia. All right, some have to do, and so you might read some of the literature on changing the environment, on the color of the tablecloths and the plates and the whole thing. It's all really important. Lighting has been studied in terms of the room where they're eating, where the person is eating, et cetera, et cetera. Um, and I found that interesting. I was okay with that, but I wanted to know what was actually happening in here because my
Mm-hmm.
suspicion was it wasn't just the you're holding the bolus in your oral cavity, right? Why are you holding that bolus there, right? And at this point, the way I think of that bolus hold, right, that people say, oh, he forgot to swallow, and I try to educate everybody. No, people don't forget to swallow, right? But that bolus hold is either there's really a swallow apraxia,
Mm-hmm.
or I suspect, and there's been a little bit of work done on this, on the attention part of it. What
Mm-hmm.
if that bolus was placed in the oral cavity and there's a fly over by the curtain and the person's just focused on what the fly is doing and they totally forget that they have that food in there, right? And I learned from back then they were called nursing assistants. Now there's all these other terms depending on the facility you're in. I learned from a nursing assistant with a lot of experience that sometimes if you place an empty spoon or an empty fork, right, in the oral cavity, you push down on the tongue, suddenly everything starts working again, boom, and they propel the bolus posteriorly and swallow. So
Right.
all those little things we learn, right, in clinical practice. So that got me interested into, okay, how we need to start looking at this, right? And oh, they developed an aspiration pneumonia, but was it because of how they were being fed? Were there really problems with, the changes in the physiology? In acute care, people weren't always doing an instrumental exam on them. Oh, they're demented. Let's just see what they can handle. It was all about texture modification. I said no, and luckily, Dr. Namasivaya McDonald, agreed. Let's look into this. So one of our first papers with this population was actually we looked at quantifying airway invasion and pharyngeal residue in a retrospective sample, and we looked at 58 patients retrospectively. And what we found for thin liquids, and this study, yeah, thin liquids and semi-solids, what we found was there was residue was more common in the vallecula, okay? But the residue that was most unsafe was the residue in the piriform sinuses, right? And so the
Mm-hmm.
residue in the piriform sinuses was more often unsafe, meaning it would spill over and enter the airway than safe. And so from our data there, we were able to analyze and find out that there was a 2.83 times greater relative risk of penetration or aspiration in the presence of thin liquid piriform sinus residue. That blew our mind because we always thought the semi-solids would be the ones that would create more residue. Why are the thin liquids creating more residue? And why in the piriform sinuses, right? Why is that the greater risk for aspiration and not vallecular overflow, for example? And so we don't really have the answer yet. This was back in 2019. But I will say, I will share that that it made us start thinking about, again, sensory inputs, right?
Mm-hmm.
So again, taste, temperature, texture, volume. So how can we manipulate that to make that different, right? And then, of course, when there's airway invasion, not everybody coughs. So sometimes there's a silent aspiration and sometimes it's not, right? So that's been really interesting. And in that context, as we're thinking about that physiology, I need to talk about Dr. Sonia Molfenter, who's at NYU. And she and her lab have been doing some really interesting work in healthy aging. Right. And she did a study, she published a study, I believe that she started this train in about 2018 was her first paper, if not before that, um, where she did MRIs of the pharynx. Okay, so looking at healthy older people's pharynx. And one of the things that she found, in addition to other things, of course, but one of the things that she found is that the lumen of the pharynx, in other words, the space inside the
Mhm.
pharynx, is larger as we age. And you say, why is that? Ah, because of sarcopenia, right? So we've heard about the changes in muscle fibers as we age, right? And we see it in our legs, we see it in our arms. Those are skeletal muscles. What are these? These are skeletal muscles, right?
Yeah.
So there's sarcopenia going on. In the 90s, when Joanne Robbins and her group started talking about sarcopenia in our field, they were looking at the tongue. And we have tons of information about exercises and changes in the tongue because of sarcopenia, but nobody has been looking at the pharynx. So Dr. Molfenter actually found, oh, so there's this larger space because of sarcopenia. So now the healthy older person has to work harder to constrict the pharynx to propel that bolus inferiorly into the esophagus, right? Again, a compensation, right? Presbyphagia maybe, right? A compensation that we don't think about until, let's say, the patient, again, is sick or weak, and so can't complete that compensation and that full squeeze, right? And so now she and her team are looking at, in addition to several other things, but what would be some of those exercises that we can recommend to folks that are aging healthily, right? Physical therapists, our colleagues tell people walk around the block, 2 times or 3 times, and that's good for your balance, and that's good to maintain your tone, and blah, blah, blah. Well, what do we have for this? For this area up here, for the oropharynx. So that's, I think, and it's just an incredible line of research, and it's really worth looking at. Dr. Sonia Molfenter, MOLF. Okay, so then we decided, Dr. Namasi Bayong and I said, okay, so we need to look at just the full package. But before that, we did a couple of other little things. So we looked at, there's this argument about cued and uncued swallows, right? And interestingly, with patients with dementia, we're telling them all the time, Mira, swallow, right? Swallow it
Swallow. Yeah.
now. Come on, Joe, swallow. Well, guess what we found? So in a cohort of 26 patients, we analyzed 105 swallows, cued and uncued swallows on video fluoroscopy. And what we found is that there's limited benefit to providing cued swallows to people living with dementia. We found, no major no significant differences. That's what I was looking for in terms of the response, in terms of bolus location where the swallow was triggered or pharyngeal transit time, et cetera, with cued or uncued swallows. But there's still that tendency to go with the, telling Joe to swallow pattern. But so we're like, so once again, we're like, that's very different from the non-dementia population, right?
Hmm.
Where we know there's a difference. We also started looking at epiglottic inversion, and this really was some of Ashwini's students were interested in this, and we said, hey, we have the data, let's look at it. And there we looked at 44 patients where we looked at epiglottic movement. And we know from the literature that epiglottic movement could happen for at least 3 or 4 different physiological reasons. But what we found was that first of all, the epiglottis didn't play a major role in airway protection in the population with dementia, and that it was mostly, when it was impaired, it was mostly because of changes in hyoid movement and that connection with the hyoid. So again, another physiological difference that keeps telling us, okay, the person with dementia is swallowing, differently because their physiology is changing. Um, so that brought us then, we did this big retrospective study with colleagues at New York Methodist Hospital, as it was called back then. And at that point, we looked at 106 patients retrospectively, analyzed 412 thin liquid swallows, and we compared them with the existing norms. That's why we did the thin liquids only, because we had norms in healthy aging population. And so, what we found was there were really significant differences in several biomechanical parameters, right? In pharyngeal transit time, in swallow response time, in response time to laryngovestibular closure, upper esophageal opening, and the degree of maximum pharyngeal constriction. So all those were different in the person with dementia compared to the norms in healthy aged. And interestingly, though, we didn't have a lot of unsafe swallows. Only about 17% of all the swallows were considered, unsafe. So that was another interesting finding. So we're not seeing a lot of these pulmonary sequelae, right? In this population. We're seeing a lot of other things like the malnutrition and dehydration and the not eating and so on and so forth. And so how much of it is behavioral and how much of it is the changes in the physiology? And so now we've been slowly running a prospective study, and our concern is that we just had to lump everybody in with this diagnosis of dementia. And now what we're doing is we're actually using the MoCA as a screener to categorize the person's cognitive status, regardless of the type of dementia, because we don't know. We're not doing a full dementia workup. Um, um, we don't have that kind of money. Um, but we are trying to then group our patients into mild, moderate, and severely cognitively impaired, and then looking at the swallow on video fluoroscopy and see if we can start seeing a trend. That's kind of where we are now with that research. Um, I am really happy to say that other colleagues are looking at some other aspects of dementia, um, which is great because we need the full package, right, to care for this complex population. Um, and so Dr. Samantha Shun, along with Dr. Namasebaya McDonald and Dr. Nicole Rogas Puglia in Wisconsin, they've been looking at caregiver burden, right? And that's something
Hmm.
to certainly address. We also need to start thinking about, as the population ages, do we always need to go to the tube, right? When that's not quality of life. So we need
Yeah.
to start thinking about the management. But before we talk about management, I think you had some other thoughts or things you wanted to say.
Yeah, and one of the things that I think always comes up for me is thinking about my mother-in-law when she was still living. Um, a lot of the time she would go to her primary care and it was a new medication or an increase in the dose or an update to something she was taking in addition to something there was always a new med is the point. There was always a new dose. Um, and we know there's a lot of people who have done great research on that, but having sort of this basic knowledge, if you're going to work with this population of patients, whether it's or even if it's not dementia patients, it's in acute care in general, in skilled nursing facilities, long-term care facilities, LTAC, even in inpatient rehab, which is where I started and is still my first love. You need to have this basic understanding of maybe you're not a pharmacist. I mean, I'm not. I don't know about you, but you do need to have some baseline knowledge of at least where to go if you're not sure. Talk to your pharmacy team. take a course on pharmaceuticals and polypharmacy, and that's a big impact for the general population. But again, as you mentioned, in the aging population, polypharmacy is a concern, and especially in patients with dementia, who maybe are not able to communicate and say, I took this new medication and I don't feel right. Something feels different when I swallow, or something feels different just in general. Their general overall well-being changes in response to, you watch a commercial on TV and it's for a new med, and it's like, why would anybody take that? It's like you may have diarrhea, vomiting, nausea, headache, constipation. And I'm like, well, that sounds really awful. I don't think I want to be
Yeah.
a part of that.
Yeah. I know, but the commercials look
So if
beautiful
you
though. It's
can't
at the end, they
communicate,
mess it up for you, telling you about all the
all
possible
the
side effects. Yeah.
yeah, all the dancing and the positive music and
Yeah. Yeah.
joyfulness, and then it's like, but you also could have a weird skin infection. It's like, why would you want to take
Exactly.
that? But if you can't
Yeah.
communicate that, you can't say, because you're whatever it is, the attention, the memory, we know those things work together, executive functioning. I teach my students your brain isn't just isolated to low, it's going this way. Thought patterns are going this way. They're going up and down. They're all over. Everything's interconnected. And if you can't attend to something, you're not going to be able to recall it, and vice versa. And then if you have challenges with communication because you do have some sort of dementia, you may not be able to communicate any of that stuff. So
Right.
that's one thing that I think
So
is a real challenge.
yeah, it definitely is. And that's where we can't stop the speech language in our title, speech language
Right.
pathologist, right? So let's not forget that communication piece. And there are things that sometimes through facial expressions, right, that
Hmm.
person is telling us. And so sometimes working with the caregivers to pay attention to that, or different reactions, and not jump the gun and make assumptions about it. Right. I think the other piece, and I didn't mention this before, that little by little we start learning, and there's some older data pointing to this, and of course I question it now because we don't do a good job at diagnosing the dementias, but we have some general thoughts, things like the frontal lobe dementia. Those folks tend to eat fast and overstuff their mouth, and so that's not something that the person is doing volitionally. So making sure the caregiver understands that it's because of their type of dementia that they're doing that, right? And then
Hmm.
figuring out ways to control that pattern or to change that pattern. The other piece that is starting to get more attention, just like I said before, geriatricians are realizing that medications are not absorbed the same way after a particular age, and this is in healthy aging. Um, uh, the other reality is absorption changes of nutrition,
Hmm.
right? And so maybe that really nutritious meal of 5 years ago is not being absorbed the same way 5 years later, right? And the person is not getting all those benefits. And so they still might be deficient in this vitamin or this mineral, et cetera. And so I think that's where, collaborating with our colleagues in nutrition and making sure that they have a chance to meet with the family and train caregivers on how to really pay attention to that. Um, and also in some dementias, taste changes, right? So some of the favorite foods aren't favorite foods anymore, right? So not always making those as something that impacts again how we swallow. Again, taste, temperature, texture, volume. I mean, the large influence that has on on how we eat. Um, to me, another piece with this population, and we go back to the behavioral pieces, put the food in front of them, right? We eat with our food in front of us. Let them see that food. If they want to hold something, maybe they're at the point where they can't feed themselves, give them something to hold, a cracker, a piece of bread, right? So
Hmm.
they're active, they're part of this process of eating and smelling and seeing. So
That's what I was going to say next, is the olfactory piece is so often left out. And that's one of the pieces that I learned in my clinical, my second off campus clinical was I was in a long-term care facility and I had a fantastic clinical instructor. And she would say, this isn't technically evidence-based. There's no research to back this up, but if I light an apple cinnamon candle, grandma's going to eat today.
Ah,
And
so,
so, and it was so
oh my
true.
God.
But it again
I've said
speaks
that
to
in
that
nursing
sense.
homes. I've said we need to get a candle factory that makes candles that smell like food. Yeah.
Right. Yeah, because there is a sensory piece that people often discount. That's why in some facilities they do offer finger foods as part of their mainstay diet. Even if they're on something like a mechanical soft or minced and moist, they might say, they can have a sandwich that's cut into quarters because then they can hold it and still have that motor piece engaged with the sensory piece. And when we're
Yeah.
looking at even teaching students, that whole motor engagement piece of writing something out helps them retain versus typing, and it's a different input.
So in my dysphagia class, which I taught dysphagia for years, I think this is the first year I'm not teaching a dysphagia course. But I always ran several labs, right? Labs on thickening things and changing textures and then making students actually drink and eat the stuff, so that they understood what they were recommending. But the other thing I incorporated because of a personal experience was I have them feed each other, right? Because as adults, we're not used to being fed, right? Unless it's,
Right.
chocolate covered strawberries and champagne, but that's usually in another context. Um, so, so I was in a situation years ago. My husband and I like to entertain, right? We had a big party, blah blah blah, and so everybody left. It was time to clean up the kitchen and all that stuff, and that's what I was doing. And here I was, washing the stemware, right? So my hands were full of soap, and I'm washing the stemware. And my husband says, "Oh, is this your glass of wine that was in the living room?" And I said, "Oh yeah, bring it over." And it was good wine. We served good wine that night. So he's like, "Oh, here, I'll give you some." And here I am standing in front of the sink, my hands full of soap. I turn my neck. So already I'm in a bad situation, right? Because I turned my neck. And and then I see this glass coming towards me, right? And I immediately say, "Oh my gosh, wait, there's too much liquid in there. I'm not going to drink all that at once. What am I going to do? What cues will I use?" And I realized, "Oh, pucker your lips," right? So then now the glass landed between my lips, and I was able to control how much I took. And then with my tongue, I pushed it out. And my first reaction was, oh my gosh, all these adults that when I do my
It's so
clinical exam,
weird.
I'm feeding them, right?
Uh-huh.
I'm not giving them the cup, I'm not giving them the spoon, or the folks that are being fed in the dining room at the nursing home. And it just changed my whole perspective on that.
Hmm.
And so now I'm much more, this was years ago, much more conscious about making sure, if the person can't hold the cup and feed themselves, I at least have them put the hand over my hand so that they can be a part of it. And with the spoon, I make sure that they understand, see what we're doing. Again, they have the food in front of them, not the spoon coming from nowhere and suddenly it lands in the oral cavity. Um, but those are the little things we don't think about where they might lead us to a misdiagnosis, right?
Yeah. Well, and think
Um,
about the impulsivity piece for, some patients with dementia, depending on the type, but also for me, working with a lot of TBI patients across the life continuum. There's nothing better if you're looking at impulsivity during the modified barium swallow than to hand them the cup because guess what? At the end of the day, when you leave to go home and they get their meal tray and no one's with them, they are chug-a-lugging like nobody's business. And so,
right.
yeah, we want to see is it, there's a lot of people who will go, oh, no, no, you don't do that. But you want to see what happens when you're not there too. We can't always control all the variables as much as we'd like to think
Yeah.
that we can. And if we can get it on fluoro or during a fees and see what happens, then we can start to develop our not only our treatment, but do we use compensatory techniques and are the patients going to have the carryover or are they going to have caregivers who are going to have the carryover to help them implement it when you're not there?
That's right. We can't forget the real life part of this, right? We're doing this exam in radiology. It's an esoteric environment, and actually, when I was running some videos for my dissertation, I had to really fight to, in addition to some of the calibrated SIPs, to also use in my study some cup SIPs, right? And I'm happy to see that now more and more in the literature because that's how a person actually drinks. They don't drink, a 10 cc
Yeah.
bolus from a medicine cup, right? They drink it from a cup. And so that's been great. And I have to thank Dr. Katrina Steele and her lab because they came up in terms of research, how do we know how much the patient took in? And so she came up with a great idea of using a scale. And so
Hmm.
we have a scale in radiology. We weigh the cup when it's empty. We weigh it once we put the barium in there, and then we weigh it again after the patient takes the sip. And so now we know how large that sip was, and that's how we do our stats, and we can figure that out. So I will forever be grateful to her and her team for that. But that's the reality part of taking then this data and bringing it home. Um, we need to be comfortable if we're working with this population with the literature on the benefits of PEGs, which are minimal, right? And
Yeah.
we've had this literature available to us since I want to say the mid 90s,
Hmm.
right? PEGs don't improve quality of life. PEGs don't prolong life. And PEGs do not improve nutrition. And we have study over study over study over study proving that. And there are still people out there recommending PEGs for the 92-year-old with advanced dementia. That's horrible. Okay.
Yeah, I agree.
So get comfortable with that literature and really be comfortable in saying that to your medical team, right? Clearly, we can't say to the caregivers, "Oh no, don't go for the peg," right? If it was offered as an option, okay, there's the pros and there's the cons, and then you have to keep it as neutral as you can, right? But even if the family chooses the peg, I feel as a clinician and as a fellow human being that specializes in this, I want to figure out what this person can handle safely so that and ask the caregivers to provide them that oral stimulation, that satisfaction of eating something, right? So maybe they need the peg for nutrition, but how about their pleasure? How about that
Hmm.
tapioca they love? Or how about that that pudding that's so great, or whatever else they might really like. Because the peg might be in there not because of a real dysphagia, but more because of a behavioral issue with their eating and et cetera, right? So we need to think about that. Also, we shouldn't discount the possibility that someone might benefit from therapy. Okay.
Hmm.
And Samantha Schoon and Ashwini Namasewaya McDonald actually published a paper, I think before they got into the caregiver burden or around that time when they were starting some years back, on looking at specifically at tongue strengthening. You know, can people with dementia benefit from something like tongue strengthening? Well, again, people with dementia aren't one package. There are different types of
Hmm.
dementia, there are different severities. So if they're following some simple commands and they can push against the bulb or they can do this or they could do that, let's maximize that because that means that they can benefit then from some direct neuromuscular therapy to help increase tone, make it through some of the sarcopenia, et cetera, so they can continue to eat orally safely and efficiently, right? We can't forget that part of this of our role in maintaining quality of life while maintaining safe and efficient swallowing for folks. So, and I guess with other treatments, there are some, you know, I don't want to say crazy things, but some not proven, not super evidence-based things. So sometimes I will suggest that if the patient is willing to do it, right? I mean, patients vary, to engage in some singing. Get the
Yeah.
caregivers to sing along with the person with dementia. Why? Why is that important? That's important because think about what you're doing to the respiratory system. Think about what you're doing to the overall skeletal musculature up here in the oropharynx, right? And they're moving their tongue and they're coordinating the breathing, and how does that impact swallow apnea eventually? Have no evidence for this. I have no evidence that says that this helps. But to me, it's one way to get into maintaining that range of motion, maintaining some of that function for me, in the context of being able to eat by mouth, right?
Well,
Um,
it also is attention and memory. You have to recall the lyrics,
there
or
we
at
go.
least some of them, and recall the
Yeah,
melody. It's a social thing, much like eating, because now you're socially singing that
yep,
replicates things like church or people who sang together in college or people are car singers, you
exactly.
know?
The car singers. Oh my God. Well, I thought you were going to say shower singers, but yeah, I'll go with the car singers. But yeah, yeah, no, that's totally true. That's totally true.
Yeah.
Um, so there's a lot that we are still able to do. I think as acute care clinicians, sometimes we shortchange ourselves in our role from not only assessment, but also in possible treatment and in counseling. Um, we sometimes then say, okay, so the person with dementia came in but they came in because of a broken hip. Now they had a hip replacement. So now they're going to rehab. So now the speech pathologists in rehab, are they not going to work with this person or look at the potential they have to do better? Because we're just going to focus on the physical therapy for them to start, walking and dancing again. Um, so, so are we shortchanging what we can really do to improve this particular patient population's quality of life? I certainly hope if I ever get there that I'm treated by an outstanding clinician that will let me continue to enjoy my martinis. I will not be thickening my martinis, by the way, um, as time goes on. So really important stuff. And then I have to slap us in the face with a reality check. When we talk about inequities, right? When we think about just healthcare disparities in general, very often we're thinking about race and ethnicity.
Hmm.
And very infrequently do we start thinking about ageism,
Hmm.
about, let's say, about this specific population, and start watching out for the literature and the work being done in Wisconsin by Dr. Rayleigh Loy. She's doing some great stuff along with Dr. Nicole Rogas-Puglia and their team up there. We recently, she got several of us together and published a paper on eating and swallowing care disparities in people with dementia. Okay, and she really is working on this conceptual framework that looks at the individual, at the system, and at the community, right? Those different levels as factors that influence person-centered eating and swallowing care, right? Um, there's also another important piece, not only with this population, but in general, is access to food, access to texture modification, access to the tools to modify textures. And I think these are conversations we need to have with the caregivers because we can't assume that they have a blender or that they are able to get one of those, quick choppers, right? We might say, oh, that's only $20 on Amazon, but not everybody has access to Amazon. Not everybody has the $20 to buy that chopper on Amazon.
Yeah.
So, those are all factors that are really important for us to think about and to now start incorporating. Our counseling is so different from, I mean, I think about the way I communicate with caregivers now compared to even 5 years ago. I'm so much
Hmm.
smarter now. And 5 years ago, I was smarter than 5 years before that, right? Because we keep learning. And I think yeah, this is all complicated, but oh my gosh, what a beautiful challenge. And what a
Hmm.
beautiful challenge when we're able to help somebody um, continue to eat and enjoy life through some good food. And I'm going to end with a quick story because I know we're getting close to wrapping up. But so acute care, right? This was years ago, back in the early 90s. I'm old, right? So back in the early 90s, um, we have this actually 92-year-old man with advanced dementia at the hospital. And the medical team at the time wanted to place a peg, right? He was malnourished, he was dehydrated, etc. They wanted to place a peg. The daughter was struggling. The daughter was the primary caregiver, and she was struggling because he because he didn't want this. He had his healthcare proxy and all that, and he didn't want tubes. He didn't want any of that, right? And he was quite dysphagic. He was really having a hard time swallowing, and so she was torn with, okay, so we need to, he needs to go home, but they're telling me he needs a tube or else he's going to die, right? And this and that. So she wanted me to decide for her. I said no. Again, I did my pros and my cons about the peg tube, and so she chose to. And unfortunately, I was almost going to call the ethics committee because I was really mad at this person's medical team. But this was back in the early 90s. Bottom line is, she decided to take him home without the tube. All right. Years later, she walks into my office with a smile and she says, "You don't remember me, do you?" And I said, "I totally don't. Tell me, who are you?" And she tells me about him, and I totally remembered her. And she was just starting to have some trouble with pills and so on. And so she was so excited when she heard that I was still at the hospital because she always wanted to get in touch with me to thank me. Guess what? Her father lived for another 6 months, advanced dementia and all. Some days he ate, some days he didn't. And she kind of knew from what I had told her that that was going to happen. And she says to me, and the day before he died, he had a whole bowl of tapioca, which was his favorite dessert, right? And for the first time in months, he looked up at me and smiled. And the next day he passed away, and she was in peace. He died with dignity. He was in control, and she was really grateful. So remember that. We don't always get to
Yeah.
hear these stories after they're discharged from the hospital.
Yeah, no, 100%. We don't. And yeah, I'm with you in that things change in the role of how we counsel our patients and our how we provide education to the caregivers and support to the caregivers. And I've been really pushing for that because, that could be we could do a whole nother hour on this whole thing, to be honest. Um, but
Yeah, but
I'm
we
so
won't.
grateful.
But we won't right now. Yeah, but we could.
No, we'll do that at Ashland. It'll be fine.
Yeah, yeah.
Um, I just really thank you for being so willing to come on and share your knowledge and share your research. You've always been such a shining light for me when I attend your talks. And so this was kind of, you were on my bucket list of folks. So I'm very grateful that you agreed to do this podcast. And I'm looking forward to seeing what you continue to do and being
Oh
able
my
to
gosh.
meet up soon, hopefully. And
Well, thank you so
Yeah.
much for having me. I want to thank the audience, thank people for listening, and I hope this is just the tip of the iceberg, and we all get, to read some more, learn some more, and start looking at different perspectives so that we can continue to provide the best care and be the best clinicians that we can be.
Yeah, I agree. Again, Luis, gracias, and hope to see you soon.
De nada, Renee, and thank you all for being here. Have a great rest of your day or evening.